normally need to see muscular adaptation. So just to review and provide some sort of definition for you, again, some of these definitions might be tweaked a bit depending on the source, but this is what I like to use. I like to consider BFR as an intentional alteration of blood flow or limb blood flow using an externally applied cuff or band during rest or during exercise. We're simply not trying to just completely cut off circulation for prolonged periods of time, and the cuffs are placed proximal on the limbs, below the deltoid insertion on the upper extremities, and as high as you can go on the lower extremities right below that gluteal fold. And then, of course, many resistance applications use relatively low loads. Typically, we'll see 20 to 30% of your one rep max. And once we get into that strength phase of things, I'll kind of go through a little bit more of a typical protocol that you've probably heard of or you typically use. All right, so when we talk about benefits to BFR in a snapshot, there's a lot of research benefits now with BFR. But across the literature, we have seen BFR associated with increased strength, hypertrophy. It's helped attenuate atrophy. We increase muscular endurance. We have seen aerobic adaptations, enhanced neuromuscular recruitment, and other critical outcomes. Evidence strength is not identical, though, for all of these outcomes for each one of these items, but I really want to show you that application is clearly broader than just hypertrophy alone using BFR. So again, let's start. I'm just going to keep bringing back the word reframe. Let's try to reframe how we can use this modality in different stages of this continuum. All right, so why is this important? Why is BFR important? Why do we care about it? Not every patient can lift heavy. Think post-surgical, think deconditioned, think injured, as well as not everyone has adequate equipment access, time to have an hour and a half to 2 hour session, traditional training session, exercise tolerance needs to be taken into consideration, as well as exercise preference for heavy traditional training. BFR gives us another tool, but it also solves a real problem. So for example, as we get into this continuum later on in the webinar, I have a few different athletes that I work with and individuals with Gen Pop. I have a 5-year-old now that I am training that uses BFR, as well as my 19-year-old heading into his college athlete soccer season using it as well. They're both benefiting BFR, but I'm programming them strategically different on how it suits them as the athlete. So again, it's not just a one-size-fits-all. Let's just use it in this portion of the rehab protocol. How can they benefit, and are we solving some sort of programming problem? So the rehab to performance uses, of course, we can use it when I'm going to get into the protect aspect of things early on. Then we're looking at restoration, where we're using it in early rehab. And then from there, we can get to the more fun part of using BFR. I'd like to consider it the more fun part where you're using it a little bit more during return to play performance aspect. You can program it in, use it with your other traditional exercise loads and modalities and things like that. So I have up here a lot of people can benefit, and a lot of different populations are now being researched to really benefit from BFR, all the way from fitness to sports rehab to cardiac rehab to neuromuscular disorders to aging. I could throw up a bunch of more populations here. All these populations can benefit from BFR, but are all the protocols and programming a one-size-fits-all solution? Obviously, the answer is no. So just to review, for those of you who would like a physiological review here, I'm going to try to keep this to about 2 minutes, 2 to 3 minutes, just as a quick snapshot review. Obviously, physiology is my bread and butter. This is where I'd love to talk about, but we would be here all night if we were talking, really taking a deep dive into what happens. But let's just kind of do a quick review here. Those of you who remember the size order principle on activating muscle fiber types, we typically need to lift higher loads or mechanically load our body pretty heavily to activate what's called our type 2B or type 2X muscle fibers. Those are our big muscle fibers. When those are activated, we can lift heavy weights, we activate anaerobic pathways, and that's what's going to cascade increase in strength and hypertrophy when those muscle fibers are activated. Typically down here, when we look at our type 1 muscle fibers, when we look at low loads, low intensities, we're really just activating those type 1 muscle fibers, which again are our aerobic muscle fibers, rich in myoglobin and hemoglobin content. They use oxidative metabolism and don't take much of a mechanical effort to activate. So low loads, low intensities here. So, but remember what I I just said, can everyone lift heavy, or if you're post-surgical or you're injured, can we get everyone to that 75 to 85% range, rep max range? No. And so when we're lifting low loads, low intensities, we're really just activating these smaller quarter motor units. So therefore, that's why we see a lot of atrophy, muscle wasting, and decreased strength decrements happen fairly quickly, post-surgically, and in the injured population. So the whole point here is, how can we use low loads, low intensities, but activate these big muscle fibers here? And this is where BFR is a great tool to do that, right? So what we're doing with BFR is we are, by manipulating blood flow patterns, we are promoting blood cooling in our capacitated vessels, okay? We are restricting or altering blood flow to the area, so less oxygen and blood, nutrients are coming to the muscle bellies, as well as we're reducing the metabolic waste clearance. We are creating an ischemic and a hypoxic environment, so decreased area of blood flow and decreased area of oxygen capacity. So what is happening here on our normal recruitment patterns, when we're traditionally lifting heavy weights, we are traditionally loading heavier to activate these type 2X muscle fibers. Here with BFR, we are using low loads, low intensities, but manipulating blood flow patterns, and by building up metabolic waste and reducing waste clearance, our earlier muscle fibers was type 1 fatigue quickly, so therefore we have to activate the next muscle fiber size and then the following muscle fiber size. Again, we're using lower loads, but higher rep range, higher volume to get to that stage. So ultimately, we are tricking our body into thinking we're performing high intensity exercise, which we are from a metabolic standpoint, but we are just doing it by manipulating blood flow patterns instead. Again, I could talk all day on the physiology of it, but that's really kind of it in a nutshell here. So our proposed mechanism, there isn't really one single BFR mechanism that's really driving us home here. There's a lot of proposed contributors that include motor unit recruitment, metabolic stress, cellular swelling, anabolic hormone responses, and signaling pathways such as mTOR. These are likely interact with one another instead of acting in isolation by themselves. I want you to zone in here too on this anabolic hormone response, which is growth hormone and IGF-1. That's a secondary response to that increase in metabolic stress in that local muscular environment. We're sending a signal to the brain saying, hey, we're inducing high amounts of metabolic stress down here. We need some help. So therefore, growth hormones release from the anterior pituitary glands, which then in turn release these IGF-1 later on down the line. And I just want you to remember, those are systemic hormones that go everywhere throughout the body, and they help build and prepare tissues in a secondary sense. Okay, so now we've hit cell swelling and our metabolic responses that are typical, it's very similar to heavy mechanical loading, but now we're just doing it from manipulating blood flow patterns with low load standpoint. Okay, so stimulus to adaptation. How does this occur? Conceptually, the BFR stimulus creates that metabolic stress, that hypoxic environment, cellular changes occur, and those alter our recruitment and signaling pathways. Repeated exposures can contribute to, again, muscular adaptation. So remember the pathway, not every molecular step here. That's kind of how we recruit the neuromuscular aspect to BFR within the muscle bellies. But I also want to switch gears a little bit to the aerobic physiology section. Is that it's not just a musculoskeletal modality, it is an aerobic modality as well, because we are altering central and peripheral hemodynamics with BFR, right? So the same principle extends beyond resistance training with aerobic BFR. So applying BFR with aerobic activity, we're manipulating peripheral physiological stress during activities such as walking or cycling, or opening applications for conditioning and work capacity. So with that, what occurs here in this cascade, I really like this diagram here, is what we're doing is you're potentially, depending on the device you use, you're decreasing arterial blood flow, but you're decreasing venous output and return. So therefore, we're altering venous return to the heart, so therefore heart rate has to increase. We're increasing hypoxia and metabolites, ventilation goes up, and we activate something called VEGF, which is the vascular endothelial growth factor, which helps us lay down new capillaries within the muscle the bed so we can then bring more blood flow and remove waste more efficiently. So there's an efficiency positive aspect there. With stop BFR, arterial blood flow drastically increases, venous return increases, therefore stroke volume increases, shear stress placed upon the vessel wall increases, therefore releasing nitric oxide. Nitric oxide is a vasodilator, drastically open up those vessels and therefore increase amount of blood flow into the area there. So even though it's called blood flow restriction, it's actually really enhancing blood flow to the area and throughout the body when you think about actually how this entire modality works. So therefore, all of that can lead to an increase in maximal oxygen consumption. So not only is it a musculoskeletal strength hypertrophy modality, this is really also can really help one out in the aerobic aspects of increase with chronic training. We can decrease resting heart rate, decrease resting blood pressure, as well as increase our oxygen capacity, which is really neat. The other practitioner note I'd like to make right here is that it's really important because of this. I'd like to always make a note of this aerobic aspect, because what happens here is that you're altering central hemodynamics. So if someone is not well hydrated, their heart rate is going to go up quickly with BFR. So if they're not adequately hydrated, you're going to have a more viscous blood. And add in manipulating blood flow patterns, your heart even has to work harder to pump around the more viscous blood. That's where you might see a little bit of lightheadedness or syncope, or exercise capacity is just decreased in general. So that's just a literally quick practitioner note there. All right, so now we're heading on to a little bit more heading into the continuum that we're talking about with clinical translation here. Okay, so lower mechanical load plus greater physiological stress can create an opportunity when traditional loading is limited. And that's the reason the rest of the webinar matters. Okay, so we're going to talk now about safety. All right, and the first question I always get from practitioners starting off with BFR is BFR safe? Okay, so BFR is generally well tolerated when, again, you are appropriately screening, dosing, monitoring, and progressing your athlete. I avoid simply saying a blanket statement like BFR is safe, because safety also depends on the person, your restriction strategy that you're using, the dose that you're using, exposure, and also clinical context. So safety evidence is very encouraging out in the literature, but adverse reporting of events and evidence in higher risk populations still is limited. So you just need to take that into consideration there. Okay, so we can safely use BFR in appropriate selected individuals, but we have to be careful with the statement, again, just blanket statement that BFR is safe. So it all depends on who we're applying it to. So first and foremost, I teach everyone, you must screen first. It's really important to have some sort of screening protocol that you use, whether it's in your clinic, your university, your athletic training room, wherever it may be. I would have some sort of screening tool to use for BFR. So before altering blood flow, you're going to screen this athlete. So I want you to start thinking vascular and thrombotic history, cardiovascular status, relevant medical and neurological conditions, medications, pregnancy, wounds, recent illness or surgery, hydration. These are just a few examples I'm giving to you guys. This is not an automatic no list, just a few examples, and it's also not the entire list that are somewhat popping up in the literature. So not all contraindications are listing here, but this also doesn't mean that you can't safely restrict or perform BFR with some of these conditions. This is why I want you to reframe BFR a little bit. I don't want us to think about this as one universal list where every condition automatically means no, but we need to determine whether we're dealing with a true contraindication, something requiring medical consultation, or something that simply changes just how we prescribe and monitor BFR with your patient or your athlete in general. All right, so what I like to use here is a good reference for you to look up afterwards, and that's why I have it here, is the Australian Institute of Sport. This guidance is useful, so it gives you a jumping off point, because it separates the true contraindications from conditions that may warrant more of a medical review or individualized consideration. That's more useful than treating every comorbidity as an automatic exclusion for BFR. So one nuance just worth mentioning is that these guidelines identify sometimes peripheral vascular disease, previous vascular surgery, and to the affected limb, fistulas to the affected limb, things like that, they consider those absolute contraindications. While conditions they talk about like hypertension, VTE history, sickle cell, bleeding, clotting disorders, prior stroke, and peripheral neuropathies may warrant just medical review and individual consideration. Okay, so these are some of the major potential risks and complications that is in the table that you can find via AIS. I'm not going to go through all of it, but something like this you should have on hand when you're using, when you're trying to screen for BFR. So this is more so the slide I want you to zone in on, and how I've adapted this risk stratification checklist to help you maybe understand. You could use something very similar with your athletes. So what I typically really use are 3 zones here. Green is to proceed, yellow is to modify or to collaborate with the correct medical professional, and red is typically just, you know what, I'm not going to proceed at all at this point, or this may not benefit or be a good added benefit using BFR with this patient or this client. The decision of patient risk plus the clinical need plus the expected benefit is going to create your BFR decision. So, for example, a healthy athlete is very different from a medically complex individual. A healthy athlete with no meaningful risk may move directly into an appropriate BFR prescription immediately with you. However, someone with a little bit more medical complexity may still be a really good candidate and benefit from safe and effective use of BFR, but that could also require collaboration with their physician or modification of the intervention and greater monitoring. That's all. And then we have the red, where we just have the patients that there's an unresolved or significant risk factor where BFR might simply not be appropriate for them to use. Okay, so the next section of that's just a little bit more on C, and I'm happy to answer more questions with that if need be at the end here. The next little section I want to talk to you about before the back half of the continuum with the athletes on where we can use BFR and help program effectively to get you thinking a little bit differently about that is to touch upon devices a little bit in general. And the reason I have to touch upon categories of devices for BFR is because if sometimes people are just looking for blanket protocols to start with, or, hey, I'm just going to use this, I just want a protocol for this, and this, or I just want a generic recipe. While there's a lot of generic recipes to get you started with BFR, it's just really a jumping off point to get you started using it safely and effectively. But depending on the individual, the program goal, everything else, and your athlete, you should be programming them differently with BFR depending on where they are in that continuum that we're going to talk about here. Okay, so these are just very few devices that are out there. There's so many more out there that you could be using. So you might see some that you use on there, some that look familiar, some that don't. Over the last 12 years, I pretty much used every type of device that I can educate with out there. So if you have questions at the end or want to connect with me, I'm more so than happy to answer specific questions later on. But right now, the point is I'm just going to explain how different categories of BFR devices can alter blood flow a little bit differently. Okay? So there are many devices out there, and those are just some examples. It's not an exhaustive list, and the goal for today isn't to crown one brand for you or at all. It's just to understand the technique you're using as practitioners. That's really truthfully today is for educational purposes. So at a higher level, I like to separate systems into non-pneumatic, rigid pneumatic, and elastic or semi-elastic pneumatic approaches. These are not all designed around the same arterial occlusion philosophy you may read in a lot of Western literature. Okay, so the devices restrict differently. Okay, so what I want to talk to you about that is when I look at here, the non-pneumatic devices don't have any air pumped in. Think more of a tourniquet, a belt strap. They typically use 7 out of 10 tightness scale. They tighten up on the arm, so you don't really know how much pressure you're applying to the limb, and it's more of a subjective measure than it is an actual calculation or any sort of measurement there. Rigid pneumatic, we move on to a little bit more of a blood pressure cuff-like device material where there's no give to it, there's no flexibility to it. Here, it has the ability to cut off arterial flow. So you might read something called limb occlusion pressure or arterial occlusion pressure. It's the same thing. All it is, it's the pressure applied guide into the band onto the arm to cut off blood supply to that limb. So typically upper extremity reference is slightly higher than systolic blood pressure. So let's just say to find someone's limb occlusion pressure with a device like this, it would be about, let's say, 140 millimeters of mercury it takes to shut off blood flow to that limb. You then would program appropriately percentage of that LOP from there. So we'll get into that in just a second. And then our last category, I like to consider it more of an elastic pneumatic system. These are designed not to occlude arterial inflow. All right, these use different millimeters of mercury parameters. So we're allowing arterial blood flow into the muscle bellies there, but they are restricting and modulating outflow. So it doesn't matter if you're using really rigid pneumatic or elastic pneumatic, you can still achieve cell swelling, metabolic overload, metabolitic stimulation, and get all of those other physiological benefits from using BFR. My whole point here is just be trained well on the device that you're using and make sure you're following proper protocols with each one. So with this, again, I'm just going to repeat, rigid pneumatic systems commonly determine limb or arterial occlusion pressure. You're going to prescribe a percentage of that AOP from there. Semi-elastic systems such as Katsu or B-Strong are examples. Approaches are designed around maintaining arterial inflow while moderating venous outflow, and generally don't use that same AOP-based system prescription. That distinction matters because it's going to matter based off your protocol and what you are doing with your client or patient. I don't care, again, as long as you're using safe, effective, validated device, which one you're using, as long as you're using it appropriately and you can get safe and effective results. So that's why I just wanted to continue that from here, and I'm happy to answer more questions regarding that as well. Okay, so a number of millimeters of mercury itself does not equal the physiological dose. Cuff material, the width of the device, the compliance of the device, someone's limb size, the device architecture itself, and the time under restriction, and the exercise dose you prescribe all affect what that pressure means. So that big highlighted statement at the bottom says, not all BFR systems manipulate blood flow the same way. Pressure must be interpreted within the context of the cuff and the device being used. So what do I mean by all this? It just really means that if someone was using 250 millimeters of mercury on one device to restrict blood flow and 150 on another, you cannot conclude that the first is providing more restriction than the second, because it really needs to take into consideration the type of device you're using, the material you're using, and all of those other things I kind of discussed about. So that's why we're kind of just talking and reviewing about that there. Okay, so our pressure dosing guide would be here. If you're going to screenshot or take a picture of something, I would take it of this if you're trying to look for device differences. An LOP or an AOP-based system, you're going to determine someone's limb occlusion pressure, and you're going to prescribe a percentage of that pressure, and you're going to now have an individualized pressure guideline for that athlete. The semi-elastic or pneumatic systems, you are going to have a device-specific cuff design. That device-specific pressure protocol you're going to follow for that specific device, and you're going to maintain arterial inflow, but you're modulating venous outflow. So again, pressure values should not be transferred between devices. If you're going to use a rigid pneumatic system, then move on to a different system. Make sure you're either recalculating LOP, AOP, and prescribing from there, because again, width matters, as well as if you're using, then going to an elastic pneumatic device, just make sure you are well trained on that device as well and how to use it so you can attain the most positive results for your athlete. I have a lot of PTs and ATs who use two totally different devices. They're like, hey, I really like this device for my post-operative patients, but then as they move along the performance continuum, I actually switch to this blood flow restriction device because it's easier to use for agility and performance measures. So you don't necessarily need to just pick one and run with it for the rest of your life, and you can use different devices for different aspects of the continuum for your athlete. And I think more and more practitioners I'm talking to and I train, they're starting to do that. They're like, you know what, I really like this one post-operatively, but as we move on to strength training and performance, this one actually programs more effectively for me. It's easier to use, quicker to set up, and I can use it there and still get some really good results. So my last statement regarding that is the takeaway for this section is pretty simple, is that BFR can provide a meaningful stimulus when it's appropriately selected, dosed, and progressed. The device is a part of the prescription, not the entire prescription. Okay, so let's get into our roadmap here across the continuum. So to protect, when we're in that protect phase, we are trying to minimize atrophy and maintain muscle. I'm going to use a post-operative ACL athlete getting all the way to perform as an example throughout this continuum here for it easier for viewers to understand. Then with restore, we're going to really hit on, this is where we're rebuilding muscular capacity with limited loading. We still can't mechanically load. Strengthen, this is now where we're starting to transition towards a more meaningful mechanical load process in the continuum. Return, now we're really trying to restore work capacity for that athlete, and we're increasing sport-specific demands for them. And then lastly, along the continuum, I like to call it their performance aspect, is now we are strategically augmenting training with BFR. Where can we do that to help their performance more so than anything? Okay, so let's move on to the first section, which is to protect. Okay, so protecting is we're going to use a clinical example here. The clinical problem is that the muscle needs stimulus before the tissue can tolerate significant load. Think post-operative, think injury right now. That may mean activation work, isometrics, very low load exercise, early post-operative exercises, and really focusing on atrophy mitigation or selective passive BFR applications. I really like to add in an MES right here, neuromuscular electrical stimulation. So let's just use that post-operative example yet again. That sometimes you can't compromise joint angle, the integrity of the tissue, or the surgical site. So therefore, a lot of these muscle fibers are pretty dormant, right? So that's where we see drastic decrease in strength, atrophy, and so forth. How can we help mitigate that? It's not going to get rid of it completely. I like to use BFR in a passive sense, as well as adding, an example would be adding neuromuscular electrical stimulation. So for example, you can involuntarily contract the muscle fibers while manipulating blood flow patterns, but you're not compromising the surgical site or the joint angle there, but we are still providing a physiological internal stimulus to the muscles that need it. So this is a really good example of what we're doing with protection. You can also start thinking things of like quadriceps, heel slides, all those other kind of things that are very early on post-operative when we're trying to protect the tissue, but we're also trying to maintain the integrity of our tissue as well. These are just some examples my colleague had sent me. He's like, you can throw these up here for orthopedic sense that he's used. I could probably have 10 more slides that he's used BFR with immediately post-operatively as well, that he pretty much starts on early on during his protection phase. All right, so right here with our key concept to protect, this is where BFR has clear clinical value. The patient can't yet tolerate the mechanical load. We normally want to challenge that muscle. So mechanical loading capacity is down, but the need to preserve muscle stimulus remains. So this is one of BFR's clearest clinical opportunities for you to use BFR is that post-operative. So now we're moving on to the continuum. We're moving on to restore, a little bit more past the protect aspect in the middle of the continuum here. So now the goal shifts to restoring muscle size and strength. Low load resistant BFR, often around 20 to 40% of 1 rep max, with higher volumes, short rest work, can create very meaningful muscular stress without requiring high external loads. Okay, some of these examples will include knee extension, leg press, squat, step up, and hamstring work when appropriate. Again, we're creating meaningful muscular stress without requiring, we cannot load the patient yet. We can't get them, or the athlete, we can't get them to heavy loads here yet. This is where you're going to see that typical protocol you probably research a lot out in the literature, is where the load is anywhere from, just consider low loads, 20 to 40% of 1 rep max. A lot of the volume is showing you 30, 15, 15, 15 rep scheme with short rest periods in between the 30 to 60 second rests. The effort is to accumulate meaningful local fatigue. Now, when I'm showing you that 30, 15, 15, there's other aspects that you can use. I've used 30, 30, 30, 30. So it's 30 reps, 30 seconds rest in between, 30 reps again. Or you could get it towards fatigue. The point here is when we're really trying to activate those type 2 muscle fibers, induce cell swelling and metabolic overload, the rep scheme truthfully doesn't really matter. You need to really get to your athlete to muscular fatigue. One of my athletes could be more deep conditioned than the other, and I'm getting them to fatigue at rep 22, where my more high octane athlete might be getting towards that 1 to 2 rep failure range within that 30 to 32 rep range. So as long as you're producing meaningful muscular fatigue and inducing cell swelling, I don't want you to just blanket statement, you got your 30, 15, 15, 15, because it might be slightly altering per athlete and per conditioning level. So just keep that in mind. Okay. So now we're moving on to the strengthen aspect. So this is where we have used low load BFR. We're inducing some hypertrophy. We're inducing some muscular strength, and now the tissue, the integrity of the tissue is healing. We're getting stronger. We can now move our athlete onto the continuum. We're heading more into the traditional strength phase of the continuum here with the athlete. Okay, so this is where we're going to talk about how BFR is typically not the ceiling, but as capacity improves, BFR should help facilitate the loading, not completely replace it. So early on, low load BFR may be a major stimulus in that rehab process. But as tissue tolerance improves, traditional loading increases and the BFR reliance is generally going to start decreasing. Heavy resistance training becomes now more increasingly important. However, does this mean that BFR needs to leave? Nope. It can stay, but its role is going to change. All right, so this is where now we're heading towards the strength performance aspect. Is we don't need to just say, see you later, your cups did its job, early rehab, now we're into the traditional strength phasing, I'm done with BFR. The point of this talk is, how can we use BFR to augment what we're doing in later aspects of this athlete's continuum? And there's a lot of ways we can do that. All right, so what we're going to talk about here is the primary strength work is really going to build our foundation, and BFR can stay as targeted accessory work. For example, for a persistent deficit, additional hypertrophy volume, a specific muscle group you're looking to target, or extra stimulus without proportionally increasing joint load, its role is just changed. So I'm going to give you an example right here, is that a traditional lower body strength section to help you understand the concept I'm trying to give you right now. Is that if I'm working with an athlete and I am loading them significantly with a mechanical load exercise regimen, I might be doing a leg day for that. So we're looking at squats, leg press, RDL or hinge, and higher load knee extensions as appropriate or tolerated for the athlete. So that's the bread and butter of the exercise session. Where could BFR help that athlete still along this continuum? I typically like to use BFR then as accessory work. I would use it as to maybe help target a persistent quadriceps deficit. Maybe they still have a little bit of a deficit in activating and strength and training with that quad, so I use that at the end. I can add hypertrophy volume. I can isolate specific muscle groups that I really need to work, but without adding extra mechanical load because I already mechanically loaded them earlier on in that exercise session. So we don't want to keep continuously mechanically overloading them because we don't want to increase risk of energy or muscle tears or any of those other kind of things. But again, I like to call BFR almost like icing on the cake in this situation. So at the end of the session, I can do some targeted accessory work to get that extra cell swelling response, that extra metabolic boost, as well as that extra neurohormonal cascade, which may indirectly during the recovery process help them recover from what you're doing from the mechanical loading phase. All right, so I really like to use BFR with accessory work in my traditional strength training athletes. So, and I also like to program them on their active recovery days. So if you're getting some delayed onset muscle soreness because now we're mechanically loading them a little bit heavier, I typically like to then add in active recovery days because we're not mechanically loading them, but we are significantly physiologically stressing them to get a better benefit. So just a quick story, I've talked with multiple strength coaches and PTs and everyone over the years, and I would have a strength coach come up to me and say, hey, I think BFR is great for early rehab, but with my strength athlete, my linebacker, I have no use for BFR. And I said, if he's healthy, of course he goes, I would never give up, traditional heavy lifting for BFR. I said, no, I wouldn't expect you to either. I said, especially if the success of their sport depends on how much weight they can lift, or if they can stop a 300-pound man running at them, it's extremely important that your tissues can load, right? I'm like, but if you ever thought of using BFR as icing on the cake or accessory work or an extra hypertrophy volume or recovery volume on their off days, then I explained the whole thing, and they're like, oh no, I never thought of it that way. I thought it was just a this or that situation. And I'm like, no, that's why we got to reframe BFR, and how can we actually help that linebacker, maybe help with recovery or increase workload capacity or aerobic capacity on their off days. And that's just an example for you there. So now we're moving on to the return play aspect of the continuum. All right, so here I want you to ask, what capacity am I trying to restore? Is it strength, hypertrophy, aerobic capacity, local endurance, training volume? You can pair BFR with walking, with cycling, conditioning, circuit training, work capacity development, and not only resistance exercise sets. We got to get out of the mindset it's just this 30, 15, 15, 15 type of modality. Where else can we put it to really increase our health benefits here? Okay. So walking, cycling, and conditioning can target aerobic capacity, like we talked about, local muscular endurance, peripheral adaptations, and work capacity. This is where I want you to stop thinking again 30, 15, 15, 15. So we're going to talk about a program problem. What problem are you trying to solve? At this stage of the continuum, it's not really a rehab protection problem or a limitation problem. It's a performance problem that I want you to, maybe could BFR help, maybe it can't. But I just want you to start thinking of that in that aspect. So I don't want you to really start with the cuff or the band. I really want you to start with the programming problem itself. If conditioning is the need, maybe aerobic BFR helps. If impact is limited, maybe low impact conditioning will help. Choose the application that addresses the actual constraint to your athlete, not just where does the cuff, or I have these cuffs, where can I throw them in? Start with your programming problem and see where you can supplement BFR into that. So again, I'm going to give you a practical example. So we're going to use low to moderate cycling with BFR during selected intervals as an example. So the goal is work capacity in this example with relatively low impact and mechanical exposure. You might progress duration from 10 minutes, 15 minutes to 20 minutes as tolerated, but the real prescription still includes the device choice, intensity, duration, restriction strategy, and interval structure and its response. Again, it's not a universal blanket protocol. There are some really good protocols out there that give you a good starting point for aerobic work. So for example, it will say exercise 10 to 15 minutes at 40 to 50% or 60 to 80% LOP for 10 to 15 minutes at a moderate cadence. It's a really good starting off point to get you started, but then you're going to be the one taking control of the programming for your athlete here, and where could BFR fit into your athlete. Okay. So here we're going to do our BFR continuum check. Protect. I really want you to start thinking of, I can't load this athlete adequately. Restore. I need to rebuild muscle with limited load. Strengthen. I'm increasingly using meaningful mechanical load. I might be using BFR as icing on the cake or accessory work, or during active recovery days. Return. I need to rebuild work capacity while managing total exposure. And then now we're moving on to the performance aspect. My athlete is healthy. What specific programming problem does BFR help solve? This is where I think it can be super fun. I love using BFR with core work. I've had an athlete who really needed to work on reaction time, agility, so I always include blaze pods while still activating the having some sort of meaningful activation for that internal environment with the BFR physiological stress there. Okay, so if the athlete can already train heavy, the threshold for using BFR should be higher. It might add supplemental volume. We might manage mechanical stress and add conditioning in. support a deload or congested schedule, or target a persistent deficit. But we should be able to always explain why it's there. In rehab, again, BFR often solves a limitation, but in performance, BFR should solve your programming problem. So at this point, the athlete doesn't necessarily need BFR in the continuum. They can lift heavy, they can run, jump, train normally. So now the threshold for using it needs to be higher. What is the programming problem I am trying to solve here? I'm happy to share this with you. But in performance, don't replace a stimulus the athlete needs. Use BFR to add a stimulus to the program needs. For example, heavy strength and power may remain primary, but BFR can add accessory volume. Target hypertrophy or endurance or conditioning with less added mechanical stress or impact exposure to not hinder your traditional exercise program you're using with your athlete. Once we're talking about performance, traditional strength and power, sport-specific training remain foundation, and BFR becomes our augmentation strategy. The role now is changing. For a strength or power athlete, maybe I'm adding accessory volume without adding another heavy loading stimulus. For hypertrophy or muscular endurance, maybe I'm adding targeted volume to a particular muscle group. And for conditioning, maybe I'm manipulating the physiological demand of walking, cycling, or aerobic intervals without necessarily, again, adding too much mechanical impact or exposure to not hinder what you're doing additionally in the weight room or with your physiological training aspect. So lastly, I'd like to block my blocks into this for using my BFR strategic framework is I boil it down to 3 words. Where can I add, manage, or expand? So I usually pretty much summarize it in this aspect. I add targeted volume for local endurance, for an example. I use it to manage, to manipulate training stress during in-season or congested or reduced load periods. And then I typically use it to expand or to create additional conditioning work capacity, stimulus. BFR doesn't replace the performance program. It gives a coach just another level to pull. So for an example, is if you have an in-season athlete, a lot of the time, especially if they're high competitive season, you have already done a lot of their preseason work, their hypertrophy work, their maxing out work. You're typically not going to be maxing them out every strength session in season because you're going to increase risk of energy and fatigue and all these other kind of things. I love using BFR in season because I can provide a meaningful physiological load without adding undue mechanical physiological stress, if that makes sense. That's an example for you there. So lastly, from protocol to clinical decision making, I'm going to wrap up here because I know I'm running out of time. But right here is, I would just kind of like to sum up that I want you to start thinking about, start with the goal. What adaptation am I trying to create? Then identify that constraint. What is limiting my traditional training, if it's anything? Then only ask yourself at that point, what role does BFR add? Does it add a primary stimulus? Is it adding supplemental volume? Is it adding conditioning, load management? Don't, again, start with the cup. Start with your programming problem. So lastly, here's how I like to build a prescription. I always start with the person, and I move on to the goal, the application strategy, my restriction strategy, the exercise dosage, and then I simply monitor, adapt, and progress each athlete differently or groups of athletes differently. So again, there's no single blanket BFR protocol. There's really good jumping off and starting points, but there is a BFR prescription that fits the person, goal, and application and that stage of training. I know I will check in with Molly quickly to see if we have time. I know they asked me to do potentially a quick BFR demo on how to apply it to the upper extremity. I'm happy to provide that with you. But before I go into that section, I appreciate you guys having me today. It's really hard to summarize BFR or any sort of concept in a 45 to 50 minute webinar. I really hope I started to get you to start thinking about BFR differently, reframing how you can program BFR starting from post-operative all the way to performance and how its role may change, how you can use this really good tool in your toolbox to help each stage of the continuum your athlete is going through, or Gen Pop, or whoever you may be working with, or even yourself if you want to be using BFR to augment some health-related things in your life. Lastly, if you would like to connect with me, please connect with me through email. My email is right here. And you're more than welcome to connect with me afterwards. I'm always happy to chat with professionals and attendees. And I just want to thank, once again, Hawk Grips for having me here today. I know they do offer some really good BFR education. I also offer comprehensive education course for practitioners, in person and online. So wherever you may go, you're going to have really good options to kind of take a deep dive into the BFR modality and start using it with your patients and your clients. So I am going to ask Molly, do you want me to do a quick demo, or do you want to just head into the Q&A section right now?
Maybe we can do a quick demo.
Do a quick demo. Yeah, sounds good.